Good afternoon, everyone, and welcome to today's webinar, The Value of Evidence-Based Treatments for Migraine Sufferers. My name is Suzanne Folks, and I am Vice President of Communications at Research America, a nonprofit advocacy alliance. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You're listening via your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio panel, and the dial-in information will be displayed. Today's webinar will be recorded. You will have the opportunity to submit questions by typing it into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will gather those and try to address as many as possible during the audience Q&A session at the end of today's presentation. Today we have several outstanding speakers for today's webinar. For our first presentation, I'd like to introduce Dr. Peter McAllister, Medical Director of the New England Institute for Neurology and Chief Medical Officer of the New England Institute for Clinical Research and Key Clinical Research in Stamford, Connecticut. And now I'll turn over the presentation to Dr. McAllister to kick off today's conversation.
Okay, thank you. Thank you for having me, and welcome to all the participants. It's a very, very exciting time in migraine research and headache medicine. We have a whole host of new treatments on the horizon. We're getting a better understanding of the pathophysiology of migraine. It wasn't that many years ago that we kind of thought of it as a black box, didn't really understand it, but now that we have such a good knowledge of which receptors are being activated, which parts of the brain are being activated by this medical condition, it's gone a long way to legitimize migraine and headache medicine. So what I'd like to do is, it's not advancing, so if someone could go to my next slide, please. I want to talk first about migraine treatment in general. We talk about migraine as occurring basically in three buckets. The first has nothing whatsoever to do with treatment. And boy, there's a really loud piercing sound on the line. Oh, it just left. Okay. The first of the three buckets for treating migraine patients is to really take a good look at them and ask them a whole lot of questions. Migraine is a biological, autosomal dominant, genetically inherited medical condition, but it is a quintessential biopsychosocial disorder. And by that, I mean, given its inherent biology, one's lifestyle has a lot to do with how many migraines one will have per month and the severity of those and how you approach those. So we talk about a lot of things before we even get to pill treatments, and that would include things like sleep hygiene, making sure they're getting to sleep. We talk about diet and exercise, discuss fluid intake. For example, those who are dehydrated are at increased risk of getting migraines. We talk about depression, which is comorbid, and I'll get to that later. We talk about anxiety. Obesity is a risk factor for chronification of migraine. We discuss that. So part of my initial visit with a migraine sufferer is to address all of those lifestyle things. If a patient is exercising, sleeping well, meditating and practicing mindfulness, drinking plenty of fluids, avoiding excesses of caffeine and alcohol, and has a good outlook on life, that goes a long way toward decreasing their number of headaches and severity. As far as pills go, we have acute treatments. Those are generally tablets or nasal sprays or even subcutaneous shots that one takes as soon as the headache starts. And there are classes that are specific, such as the triptans and dihydroergotamine. We also use nonsteroidals here. We can accompany those with certain antiemetics. There are some nausea medicines that actually prove very helpful in not only turning off the migraine nausea, but actually helping the migraine itself. Prochlorperazine, metoclopramide would be examples of those. The new class of drugs that's come out, which I'd like to address, are preventives. And so preventives have been around for ages. The goal of any preventive medication is to, you take it, generally these are pills, and generally they're taken every day, whether you have a migraine or not. The goal is to decrease the severity of the headaches, decrease the number of headache days per month, and with any luck, they also make the acute treatments more effective. So there are a number of them approved. There are many preventive drugs that are not FDA approved for prevention, but have good evidence, either what we call Class A or Class B evidence. The tricyclic antidepressants would be in that category. The one medicine approved for chronic migraine, which is defined as 15 or more headache days per month in a migraine sufferer, is onabotulinum toxin. So that has its own little special indication. It's interesting to note that of all the preventive medications that we have, none, except for the new class of what we call CGRP blockers, none were designed specifically for migraine. They were designed for other conditions, such as treatment of epilepsy or to decrease blood pressure. And it was found serendipitously that people who were taking those for a different indication had less migraines. And then that led to clinical trials, and that's how they either got approved or into our scientific literature so that we could use them. The excitement, one of the exciting things in headache medicine is the launch on May 17th of the first of a new class of medications which block CGRP, calcitonin gene-related peptide, which is one of the major bad guys in starting the migraine cascade. And this new class of drugs blocks either the CGRP receptor or the CGRP molecule itself, and have been shown in good double-blind placebo-controlled studies to be highly effective and to have next to no toxicity and very good tolerability. So we have a whole new class now that are going to be very effective for our patients. So I'd like to move to the next slide, if that could be advanced, please. There are challenges in migraine treatment. I've been a clinical researcher for over 20 years as well as a clinician, so I see patients, but I also run all of the exciting trials at my office and around the country as well. When you're dealing with something like migraine, humans are complex and brains are tricky, so it is not an exact science. We ask patients how they're feeling, and we rely on what they tell us. And how one is feeling depends on a whole lot of factors, including genetics, how they were brought up, whether they have had trauma in their life. There's many, many different things that go into it. When you have what you think is a good compound and is safe and it seems preliminarily to be efficacious, we have to get subjects into studies. And one of the problems around the country is getting subjects in. Some people don't like the idea that they will have a 50-50 chance of getting the real drug in a study or the fake drug, which is what we call the placebo. There is a problem with the placebo itself. So reasonable brains want to feel better. And if you put someone in a study and you give them the real drug, there's an expectation, of course, that they will do better. But if you give them a placebo, perhaps somewhat surprisingly, a lot of those patients get better too. Now, it's usually temporary, it usually wears off, but the way science works is at the end of the study, we compare how well the group that got the medicine did compared to the group that got the placebo, and it turns out that sometimes placebo response is quite high. So we have to do a lot of things in our clinical studies to negate or to decrease that high placebo response rate, because that can make or break a study. All medicines have some degree of safety and tolerability issues, particularly the oral medications. It's a sad statistic, but with the oral pills that we use for prevention in migraine, upwards of 70% of people wind up getting rid of them within 6 months of starting. And it's not because we're curing the disease. Really, it's intolerable side effects and a lack of perceived value. It just doesn't help enough to warrant side effects. Again, this new class of drugs, the CGRP blockers that are monoclonal antibodies, have the great safety and tolerability on their side, which is really nice. We may actually have our patients staying on medications. The last thing is children with migraines. So 10% of all kids get migraines. Boys are equal to girls, and then as they begin to go through puberty, the boys stay the same, even go down a bit, and the girls often increase their number of migraines. Up until recently, we just treated children as little adults, and we did studies on adults and figured, hey, they may work in kids, but that's changed, fortunately. We now, and it's an FDA mandate actually, that when a study is positive, that eventually there'll be studies on adolescents, which is 12 to 17-year-olds, and sometimes we have studies on younger children. We have several migraine studies now on 6 to 11-year-olds. So those are some of the issues and challenges when you're doing clinical studies in migraine. Can we have the next slide, please? Migraine, the medical condition, tends to run with some other treatments. So a condition that's comorbid is two conditions occurring in an individual at a greater rate than expected by chance alone. So if you had migraine and, toenail fungus, those would just be random. You happen to have both. But there are a number of conditions that, probably due to similar genetics and similar risk factors, occur commonly in migraine. And when we migraine specialists treat patients, we have to keep these in mind. So a number of psychiatric disorders, including anxiety and unipolar and bipolar depression, occur more commonly in migraineurs than non-migraineurs. Is that important? Yes. We certainly don't want to use medicines that would worsen that. We also want to screen for that and get them to find ways to treat their anxiety and depression, either with cognitive behavioral therapy or biofeedback or even medications. We sometimes go for what Dr. Stuart Tepper calls a therapeutic twofer, meaning if you have a medicine that can work on depression and also has some validity in treating migraine, that's a good thing. There are some classes of SNRIs and certainly some of the tricyclic antidepressants that one might use to treat both migraine and psychiatric disorders. Other pains run with migraine. Irritable bowel and fibromyalgia are two that come to mind, but there are others as well. Other conditions, heart disease and stroke. Migraineurs, particularly those who have the visual aura, which is the minority of patients, but all to some extent are at slightly more increased risk of heart disease and stroke. Asthma and allergies, including allergic rhinitis, are more common. Epilepsy, seizure disorder, is more common in migraineurs as well. If someone has that, there are a number of anti-epileptic drugs that are approved to treat migraine, and that would certainly be the choice for them. So to summarize, this is a very exciting time in headache medicine. Migraine affects 38 million people. It's under-recognized, it's under-treated, and it somehow doesn't have the validity of other medical conditions, although migraine is constantly listed in the top 10 most disabling medical conditions. And while it's not lethal, it really impacts the quality of someone's life. So to have new medical treatments is very important. More research needs to be done, both on adults and children. And when one understands the whole person, including their comorbidities, it makes for better treatment. So I'll stop there, and I'm going to turn it over to our next speaker.
Thank you, Dr. McAllister, for your insightful remarks. Interesting that many of the medicines developed for migraine were developed for other conditions, and that we now have studies targeting children and adolescents. So moving on, I'd like to introduce our second speaker, Dr. Jan Lewis-Brandis. She holds an appointment as an assistant clinical professor in the Department of Neurology at Vanderbilt University School of Medicine in Nashville. She is also the founding director of the Nashville Neuroscience Group, a private headache clinic in Nashville. Dr. Brandis, thank you for joining us.
Thank you. It's certainly a privilege to be with you today. And I'd like to address some of the, or expand on some of the things Dr. McAllister has talked about. One of them is the fact that we know migraines disproportionately impact women. And certainly migraine is not a woman's disease or a women's disease. It sometimes is perceived that way because women at every hormonal milestone have the opportunity to have their migraines worsen. So as you've heard from Dr. McAllister, the numbers in boys and girls, actually it's a little bit higher in boys until the time that girls begin having menstrual cycles. And once they start having menstrual cycles, the numbers in women go up for migraine, and they continue to go up until after menopause, when women then either are placed on stable hormonal therapy, stable estrogen levels, or they are not placed on therapy and their estrogen levels essentially decline, fall, and also remain stable. So men never really catch up, and it's the hormonal influence. It's really the influence of estrogen fluctuation that changes the genetic predisposition in these patients for migraine. So there are many opportunities for women to have a marked worsening in their severity and frequency, and that's really the reason that migraine disproportionately impacts women. And ironically, many of the studies that have been conducted through the years, while women are the majority of the patient subjects, there is not always a great deal of data that's collected from the clinical trials related to the hormonal influences on migraine. So although the demographic for women enrolling in trials is usually women in their 40s, women who've had migraine for more than 10 years. Again, those many times we don't include information or detailed information about what's been the impact of oral contraceptive pills, what about long-acting reversible contraceptives, what about women during pregnancy. So there are many areas in research where this disproportionate impact that migraine has on women, we really don't have the kind of information, but we're beginning, I think, to see changes in that. And in terms of what Dr. McAllister, I too have been involved in clinical trials for more than 2 decades. And when we think about the challenges for migraine patients in clinical trials, there really are many. But I would also say that, Research America is part of helping us to really explain to more and more individuals that there are opportunities for being in clinical research. And one of the areas that I think is a unique challenge for women is that many times women are not really able to get into clinical trials because they can't get there. So there's some physical barriers to that. It's hard if it affects women in their childbearing years when they often have children to be managing and they're working full time or they're trying to juggle lots of things. And so it's often, if you can't get there between 8 and 5, you may not be able to participate in a clinical trial. And I think many centers are beginning to look at ways where we can expand those opportunities for women. And as you've just heard from Dr. McAllister, one of the other areas where there are challenges for migraine patients to participate in clinical trials is the fact that most clinical trials exclude women who have and men who have comorbid conditions. So, for example, if you have significant anxiety or depression, you really are typically not included in a study for, let's say, a new migraine preventive. In the new calcitonin gene-related peptide monoclonal antibody trials, you couldn't go in those trials if you had a comorbid pain condition. So that leaves out migraineurs, which we know often have fibromyalgia, or they may have cervical disc disease, or they may have another painful disorder. Those patients couldn't participate in those trials. So we really need to think about ways that we can at least have subsets of patients who have the comorbidities that are so tightly associated with migraine, because we need to see how patients with more than one disorder really respond to the medications. And I think one of the questions that, as we think about some of these newer treatments, is going to be, well, who's the ideal candidate for that? So there are really a lot of ways that I think we need to think about modifying opportunities for patients to participate in clinical trials and for them also to really learn about clinical trial participation. So I think in terms of progress slowing, that was on sort of my list of topics. When we think about progress slowing in migraine research, well, I think we see that there's a great deal of interest, and there are great research organizations that are really moving forward with, for example, both the preventive, the CGRP antagonist program, these monoclonal antibodies, which are the first in class in terms of a medication specifically directed at migraine. And the other component, though, is while you have that happening in one sphere, we also have a decrease in funding at the federal level. So the National Institutes of Health funding is really quite minuscule when we look at the numbers for migraine. Important when we think about a disorder that has an impact on 38 million Americans. So we know that these are areas where we have a great need, and yet there is a disproportionately small amount for a disorder that has such an incredible impact. And certainly the estimates for both indirect and direct cost for migraine are in the billions. So we really, I think, have to continue to increase awareness about the need for basic research involved in migraine, how we explore the comorbidities, how we explore the differences in the genetic differences in individuals with migraine, and also how we really begin to identify, are there ways to modulate this disorder we know is migraine, which can change over time, because we know that 1 in 4 individuals who has episodic migraine, fewer than 15 days, is at risk for transforming into someone with chronic migraine more than 15 days a month. So that's a huge transformation for patients. And once they move from episodic to chronic migraine, they often are harder to treat. And we know that some of the risk for that chronification or that transformation from fewer attacks to more than 15 days, and sometimes people with daily migraine, one of the major risk factors for that is being a woman. Another one is attack frequency, which is why it's so important, as Dr. McAllister has alluded, it's so important for us to have clinical trials that involve children and adolescents, because children and adolescents and people in their early 20s who start out with higher frequencies of migraine are already at risk for moving into this disorder we know is chronic migraine. And certainly anytime there is a change in hormonal milestone for many women, for example, who may simply have episodic migraine, they may not even recognize it as migraine, it's just their menstrual headache. When they move into perimenopause, where the swings or the fluctuation in estrogen are much higher and there's further to fall in those patients, that may be a time when migraine dramatically worsens and women actually come to diagnosis for the first time. So there are many areas, I think, in terms of how we look at treating these patient populations, how we really begin to look at the basic understanding of migraine. And there's still many things about migraine pathophysiology that we really do not understand. And in terms of recent research that's really made a difference in terms of patient care and diagnosis, well, I don't think there's any question but that we, I think as a country, I think not just people who are headache specialists or who are in research, but I think patients and their families, I think it really is thrilling to begin to have essentially a class of drugs that really is migraine specific. Someone on the call alluded to this earlier, this notion that we have a medication that is specifically for you as a migraineur to prevent your attacks. Now, we do know that there are some super responders to all medications, and that would include the CGRP antagonist. But I think the important thing is it not only offers a new opportunity for treatment, but it really can change the level of discussion. It's really, I was hoping it would happen in my practicing lifetime, and it has. It's very thrilling to look across the computer screen in today's world at someone and say, I believe you have migraine, or you confirm the diagnosis of migraine, and then to be able to say, we now have the first migraine-specific therapy to offer you. It certainly is a different, I think, than when we have to tell patients, I'm going to put you on this, then they look it up and they discover that the drug is used for 6 other things. And sometimes if that educational level is not really, or if that education is not part of that discussion, they may not really understand why they're on it. So that's been, I think, a thrilling advance as a clinician, and I think it's very exciting for patients. And since it's a genetic disease, it's exciting for their families too. I do think other research that is very important and continues to be important is looking at how do we really continue to improve patient care and diagnosis. And one of the things I think when we have any new treatment for migraine, it sort of allows us to go back and talk more and more about the diagnosis of migraine. There are specific diagnostic criteria that we use for the diagnosis of migraine. And I think the more those are made available and the more public awareness and the more individual awareness we have of those, it allows us not to let patients become trapped in this sort of mythology that what they have is sinus headache and they have sinus headache for 15 years before they finally see someone who goes, oh, that's not sinus headache, that's really migraine, or tension type headache, or stress headache, or cervicogenic headache. Whatever those patterns are, we need to really address migraine earlier, have a very specific diagnosis, and that may mean that someone can simply treat it by modifying behavioral factors. You heard some of those suggestions by Dr. McAllister, but it's important that it be recognized, because then we can always be on the look for when might it change, when might it chronify, when might it really become the disabling condition that it is really for millions of individuals throughout the United States and throughout the world. And I think the other area I would close with is the epidemiologic research that continues to talk about not only diagnosis, but ways to improve patient care. And we know from Richard Lipton's work and sort of his team, Ann Shear, who has been with him in the past and now has done a lot of the work on chronification, we know from them that if we don't do a good job as clinicians in terms of treating an attack of migraine well, that patient is likely to move to someone who becomes chronic and then who has a higher treatment need. So I think there are many different areas, there are many different groups involved, both from the epidemiological to the basic research labs in migraine. And we really need, I think, continued collaboration between patients, their families, basic researchers, clinicians, primary care. So we really need gynecology. We need everybody really to be involved in this enormously important and impactful disorder disease that we know is migraine.
Thank you, Dr. Brandis. Many great points, including the need to increase awareness and funding for research and finding or modifying opportunities for patients with comorbid conditions to participate in clinical trials, very important. And so we will now move to our third and last speaker, Dr. DiLeonardo. Lisa DiLeonardo is a licensed psychologist and migraine patient, and we're happy to have her join us today. Dr. DiLeonardo.
Thank you, and thank you for including me on today's panel. Could you advance to the next slide, please? So a common misperception about migraine is that it's simply a really bad headache. A headache is only one part of what it means to have a migraine. For me, having a migraine meant hours of prodromal symptoms where I felt fatigued, nauseated, unmotivated, a little bit irritable. Often it would involve brief episodes of vertigo. Then I'd have the throbbing pain and experience all stimuli being turned up several notches. Every sound was too loud, every light too bright, every smell overpowering. And even after the migraine ended, I still had to deal with the postdromal phase, which left me drained, unproductive, feeling not like myself for several hours or even an entire day. And the worse the migraine, the worse and the longer duration the postdromal phase was. It's important to note that migraine occurs along a spectrum. There are more mild manifestations of migraines and much more severe manifestations. Not all migraineurs experience migraine at the same degree, intensity, or frequency. And over any individual's experience of migraine, that experience can change. In keeping with some of the things that Dr. Brandis discussed, for the first 23 years that I had migraine, they occurred episodically, usually premenstrually, and they were pretty manageable for me once triptans became available in the early 90s. Migraines ran in my family. Both my mother and my maternal grandfather had them. The migraines I had for those first 23 years or so could be pretty intense, but they were infrequent enough that they didn't significantly impact my quality of life. I learned to control certain triggers around my menstrual cycle and was able to have them be little more than an annoyance. All of that changed for me in 2012 at age 41 and probably at the beginning of perimenopause when I suddenly began to have chronic migraine. Controlling my previously identified triggers no longer seemed to have any effect. There's the widespread misconception that triggers are causes, but they're not. Migraine is a disabling condition mediated by at least 40 different genes and a pathophysiology that's not completely known by scientists at this point in time. There are potentially identifiable triggers that can be managed, but those triggers are not causes. Could you advance to the next slide, please? Once my migraines became chronic, I was invested in the misconception that if I could control my migraine triggers, I could control my migraines. I developed spreadsheets and tracked data on different variables, things I systematically eliminated for a 3-month period to ascertain which triggers I needed to control. The myth was that I could somehow stop my migraines if I only did the right things and avoided doing the wrong things. And I eventually learned that my migraines would continue regardless of how perfect I was. This was a tough lesson for me. I'd always been a straight A student. I believed if I delved deeply enough into the research literature and worked on controlling all the right factors, I'd earn the A and I would be free of migraines. I eat a relatively healthy vegetarian diet. I sleep well. I run regularly. I also cut out certain potential food triggers. I eliminated caffeine, sugar, and alcohol from my diet for months at a time. I was vigilant about hydration. Once the process of chronic migraine had started, none of those changes made a difference. Ironically, as a psychologist, I talk with my patients all the time about recognizing that much less is in our control than we might like. My attempts to minimize these triggers forced me to face how little control I had. There were no more ways for me to put the burden of if I'd only on myself. Next slide, please. Much of the stigma around migraine exists because it disproportionately affects women and because migraine is an invisible disease. The fact that migraine occurs more frequently in women, including Serena Williams, who has been vocal about her struggles with menstrual migraine, adds to the ways in which migraine is stigmatized. Women are sometimes seen as being the weaker sex, seen as complaining, as overreacting, as not being able to tolerate real discomfort, and so their symptoms and the severity of their migraine is written off and invalidated. To avoid that stigma, some women react in the way that I often did, by being overly stoic. I tried hard to ensure that, except for maybe 1 or 2 people, no one ever really knew how much I was suffering. I would do everything I could to get myself through a workday or a social commitment, even though getting myself through invariably meant my symptoms were worse afterwards. Sometimes I could barely drive home because the pain was so bad and the light from the sun or headlights so blinding, I wanted to pull over, throw up, and curl up on the side of the road. When things were at their worst, I was making few commitments to do things to avoid the possibility of having to explain why I couldn't follow through. I didn't want people to feel bad for me. I didn't want to be seen as complaining, and I didn't want to be judged. I realize now that being stoic and trying not to ever cancel things, regardless of how incapacitated I was, only perpetuated the stigma, only covers up the real cost and impact of this disease. It also doesn't allow other people the chance to really understand and empathize with how dreadful the experience of migraine is. Next slide, please. Migraine, much like mental illness, is an invisible disease. We interact with people every day who have no obvious disability. There's no broken leg, nothing physical and obvious to point to. There are no lab tests or imaging studies we can do that prove you have a migraine or prove how much pain you're in. Part of the problem is that migraine or chronic pain conditions are seen as being inconvenient, but relatively benign diseases that don't kill you. Thus, they're not taken as seriously. This perspective ignores the huge disability and the cost to the quality of life. Next slide, please. I've already addressed some aspects of how migraine affected my quality of life, but I want to underscore a few points. When I was dealing with an average of 14 migraines a month, along with an additional 5 to 12 headache days, every aspect of my life was affected. I'm an optimistic, happy person by temperament, and it was tough for me to experience joy in my day-to-day life because managing a chronic pain condition was physically and emotionally exhausting. Migraine days were days where I would accomplish 30% of what I might otherwise get done. Physically, it was literally difficult to move at a normal pace. I was also uncharacteristically quiet. It's tough to summon the energy to talk and difficult to be present and engaged. During the work week when I had migraines, I would devote all of my energy into being completely present and attentive to my patients. They had to come first, but it meant that everyone and everything else in my life got short shrift. Many days I had nothing left over to devote to housework, family interaction, responding to friends, doing any of the dozens of to-do list items that seemed to pile up endlessly because of how many days a month I was focused on only surviving. Additionally, the medications to abort or prevent migraines impact quality of life as well. The triptans typically worked for relieving head pain, but they could take 1 to 8 hours to work, and often they added dramatically to the nausea and tiredness. In terms of preventives, I was on 2 different classes of preventive medication, an anti-seizure medication and a beta blocker. The side effects were an entirely new daily burden to manage. With the anti-seizure, I had difficulty with word finding and reading maps. I had a difficult time focusing in a noisy or distracting environment. I could not multitask. I was cold all the time and I was losing a lot of hair. When I added the beta blocker, my hair became even more thinned out. I was chronically nauseated and became even more continually cold and prone to lightheadedness and dizziness. When exercising on the beta blocker, I was running at a snail's pace, and my normally fast walking speed was slowed dramatically and seemed to take significantly more effort. Having this many side effects took something away from the limited benefit I received from these medications and from my quality of life in general. And Dr. McAllister also talked about that and the fact that so many people do give up those preventives after just a few months. There were also some non-medication things I tried that didn't have side effects. I tried riboflavin, butterbur, acupuncture, cupping, massage, yoga, meditation. They didn't have side effects, but they also didn't help to reduce my migraines. There were medication preventives I had not tried, but after 3 years of managing chronic migraines with minimal and transient benefit, I was starting to feel disheartened. Next slide, please. Then my neurologist told me about the exciting new world of CGRP antagonists. I immediately researched them and learned where clinical trial sites were. There was one company study that offered a 12-week double-blind phase with a 1-year open-label extension, the only one essentially guaranteeing I'd eventually get the active medication. All the studies required stopping preventive medication for 3 months. That seemed more frightening to me than the prospect of taking a steady drug with unknown impact. I didn't mind being a guinea pig, but it was hard to quiet the nagging fear of how much worse would I be without the preventives. This was especially true because I was trying hard to limit my number of triptans to 2 a week to avoid any possibility of medication overuse headache. So the idea of having no preventive on board for 3 months made me pretty nervous. However, the promise of knowing I would definitely be on the drug for a year made me decide I couldn't pass up this opportunity. As an aside, my fear was not entirely unfounded. That 3rd month off the preventive, I had 20 migraines that month. So I had 2 drug study sites near me. One was 45 minutes away, the other 90. The closer one runs many drug trials simultaneously, and it took weeks to even receive a return phone call from them. The further away location was a much smaller drug study site, and I was able to call and get pretty immediate access to the primary investigator who answered all of my many questions. I chose that site and had an overwhelmingly positive experience. The head of the clinic did the most thorough history and initial exam I'd ever had. And throughout my 16-month experience, I felt that everyone at the site was warm, caring, responsive, and interested. They were flexible with scheduling when I needed to change a time or even a day due to my own patient load. As a psychologist, I understand that in research we want to do our best to avoid evoking a placebo response so that we can get the cleanest data possible. Placebo effects cannot be entirely avoided when there's human interaction and when we're talking about injecting people with a substance. It seems to me that it can only benefit both recruitment and retention of subjects if study sites develop good connections with their subjects. Knowing that you're going to a place where people are warm, friendly, and make you feel valued is a helpful motivator when you have to drive 90 minutes, have blood drawn, have an EKG, give a urine sample, get an injection, and then drive 90 minutes back home. Of course, the best part of my clinical trial experience was the fact that over the course of the trial, I experienced a dramatic difference in my migraines. Not only did I have fewer migraines, but even the ones I did have were less intense, of shorter duration, and more responsive to triptans. I'm not someone who's quick to assume I can pinpoint the reason for a change in migraine frequency or intensity. There's a natural variability, and I hate to confuse correlation with causation. A change has to be maintained at a pretty steady rate for me to attribute it to something I'm doing differently. I started the open label part of the study in May. By July, I was starting to feel optimistic. And by October and November, when I had only 6 and 3 migraines respectively, I was convinced. For the last 8 months I was on the trial drug, I had a 50 to 70% reduction in number of migraines. So I was having somewhere between 2 and 6 during that time. During the entire 2 years I'd taken the standard preventive medications, I had had only 1 month with fewer than 7 migraines, with the typical range being 10 to 15 migraines a month. That's why the clinical trial drug felt like a miracle to me. Sure, I still had migraines, but I was no longer consumed with them. I had fewer non-migraine headaches. I was able to be more productive, take on new projects, commit more easily to doing things with friends and family. I was able to look forward to events without that nagging fear that I might disappoint people if I didn't feel well. Best of all, I felt my sense of joy and excitement about life return. I truly felt as though I had gotten my life back. Next slide, please. I was asked if there's anything I'd like the research community to know about my experience. I had to keep a daily electronic diary during the clinical trial. While it did include some quality of life measures, I felt as though there were important aspects of my experience not being captured. Many of the questionnaires addressed whether you did or you didn't do a certain activity. It didn't ask how much more effort was required to do things, how much longer something might take, how efficiently you were able to complete a task. No questions captured how difficult it was to look forward to things, or how many social interactions you simply endured. Even though some quality of life data was obtained, it was not a primary or secondary endpoint for the trial. I understand the data the FDA is looking for is efficacy, defined in terms of how many fewer migraines a month people experienced. However, a month of having 6 migraines while on the study drug was subjectively entirely different than a month of having 6 migraines on the anti-seizure preventative. I can't emphasize that enough. The quality of life that I had on the study drug was vastly superior because of the lack of side effects and the increase in completely symptom-free days. And when I did have a migraine, it was less intense and more quickly responsive to rescue medication. I hope there's a better way to capture more nuanced quality of life data and to make that a study endpoint because it's much more meaningful to patients and to their treating physicians. As I mentioned earlier, I chose the particular trial I did because of the year-long open label extension. Being able to definitively get the active compounds a strong selling point. It would have improved recruitment and retention rates to have double-blind studies where there's a greater than 50-50 chance of getting the study drug. By the time somebody gets to the point of seeking out a clinical trial, they're looking for better odds than flipping a coin that they're going to get a drug that could improve their life. I'm sure all of us here today agree that migraine research is woefully underfunded. The new wave of CGRP antagonists represent the first drugs developed specifically to target migraine. This is a significant breakthrough, and yet there's more research to be done. Research that will help make the pathophysiology of migraine better understood, that will develop objective measures for diagnosing migraine, and continued research to develop new targets, new biological targets than we have today. The clinical trial medication was a game changer for me, and it will be that way for many, many people, but not for everyone. Knowing that researchers are actively looking for treatments and ways to prevent migraine is a source of hope to all of us that suffer or have suffered from this disabling condition. Sometimes it is that hope that allows someone to continue battling their migraine until a solution is found. The new medication that I've that has just been approved is a concrete example of hope that came to fruition. I'm optimistic that continued research will give more hope and more solutions to more people. Thank you. And now I think we'll turn it over to questions.
Thank you, Dr. DiLeonardo. I will say that it was great to hear about your experience with this clinical trial and that this new class of medication is showing much more positive outcomes for migraine sufferers. And your point about the need to capture quality of life data, very important. So we will now switch to our Q&A portion. A reminder that you may submit questions by typing questions into the questions pane of the control panel. We do have a couple of questions. One from Michael, who wants any of the speakers to respond to how do we affect change in medical protocol across the country to embrace the reality in treating migraines and to get the word out about lack of funding for research. So I believe this is for any of the speakers to respond to.
I'll be happy to. I think it's Dr. McAllister. I think that, given the number of people affected by this medical condition, migraine, and given the disability and the lost time and the lost years, etc., we would all agree, as has been stated, and Lisa said it eloquently, it's way underfunded. So we have to make noise. So, you don't get anything by being passive. I think one nice initiative is Headache on the Hill, which is an advocacy group that goes to Capitol Hill and petitions our lawmakers. And I'd like to see, more people engaged in that. And that's bearing some fruit. I think that military coming back from, the adventures in Afghanistan, Iraq, and other places with head injuries and chronic headache will also help increase funding into that particular branch of headache medicine. But I think that we have to have an active voice with legislators to get the word out and get this funded.
And I would just add, this is Jan Brandis, I would just add that there are organizations, for example, one that I'm very involved with is the National Headache Foundation, and there are different ways to participate in that. So individual patients can participate, their families can be a part of it, other organizations. It's a way to really be part of a larger voice, and we have an active advocacy program, participate in Headache on the Hill, and in promoting educational opportunities and fundraising for research in migraine. So participating in something like, say, again, the National Headache Foundation is a way to really be more involved, to have access to more of what's really happening in the field of migraine.
Thanks to you both. Again, if you have any questions for the speakers, please type them into the questions pane on the control panel on your computer. Dr. DiLeonardo, I do have a question for you. How do you think patients are navigating the current system in finding information about clinical trials? What can they do, or what should they think of in terms of seeking that information and having discussions with their healthcare providers?
Actually, I think it might be useful if more healthcare providers actually suggested pursuing clinical trials. Interestingly, my neurologist, while he did bring up this class of medications that was being developed, the CGRP antagonist, he didn't suggest that I look into a clinical trial. And my primary care doctor had not suggested that option either. I sort of knew enough to look it up on my own. So I thought that was kind of interesting. It would be helpful if that were promoted as more of a possibility, perhaps.
And, I'm so glad to hear you say that, because and to have you participate in today's discussion, to have someone who not only has had a long history with migraine, but who also has participated in a clinical trial and sort of going through your own experiences, the positivity, the fact that you found it, your, all the things that you really took into consideration, and then saying what you really found helpful about, the structure of the clinical trial. I think all those things really are so useful. And I certainly think that having more individuals who participate in clinical trials, as Research America is doing today, really be able to tell their story encourages others. And I think that's really a great way to go about it.
And it's true, there doesn't seem to be a lot of information. I mean, I try to look up most things before I venture into them. But it was very hard to find anything online where people really talked about this was my personal experience in a clinical trial. So I was very, sort of wary about what it might be like, which is why I was also so grateful for the particular site that I chose. The people there were just fabulous, in terms of orienting me to the whole experience and the process, et cetera.
And, isn't it amazing how different any patient experience can be? If I loved what you said about it being a warm, friendly environment in which they were interested in you. And that's really what good clinical research is about. And I think the more we have discussions like this one, the more people think about that, the more we think about, because it's useful for me as an investigator, and I'm sure Dr. McAllister probably feels the same way. It's really useful to continually have that feedback, and I think we can provide that, to companies who are sponsoring these trials. I do want to just say just how much I echo your choice of trial based on the open label component of the trial, and that really is so important. And sometimes we have a hard time convincing companies, if it's sponsored research, to really include an open label trial, and that is one of the ways that it's sort of like it's a way to really give back to a patient who chooses and who really makes the sacrifice of being potentially on placebo, even though, as Dr. McAllister pointed out, placebo sometimes in pain trials it works.
Sure.
But it really does, it really is a very important component, I think, of how clinical trials encourage individuals to participate. So I'm really glad that you brought that out, and I'm very glad that you had your experience with the trial. It's really breathtakingly exciting, even after 25 years in migraine, to hear someone talk about their experience in the way that you have. And so as a clinician, I have migraine too, and I have two sons with migraine, but it's just your openness and your willingness to talk about this in this forum, and Research America's alliance for discoveries in this area. It's just, these are the kinds of conversations, and this is the kind of information that I think really can change people's lives.
Well, we do have some questions coming in. There's one from Maja. What suggestions do you have in how to address a chronic migraine condition with employers? I often find that employers do not have an understanding of the effects of migraine. And this is for any of the speakers.
Well, I mean, I think that, one thing would be education, educating. If it's a small company, your boss or bosses. If it's a large company, your human resource department. Migraine is among the most disabling conditions, as we said, and that applies to work. And we talk about absenteeism, so it's not good for their bottom line to have an employee consistently out if you're having 17 or 22 or 30 migraine days per month. But we also talk about presenteeism, in which you're there, but you have the residua of yesterday's migraine or one that's beginning, and your productivity is markedly diminished. And if you think about, this striking in the prime work years in both men and women, but women get more of them, plenty of women in the workforce. So this medical condition clearly will affect companies' bottom lines, and I think the smart company would take that into consideration, get educated on the disease state migraine, and find simple ways to have their employees maximize their quality of time in the job situation. It could include something as simple as in their office getting rid of the fluorescent lights in favor of an incandescent light, or giving them time to take a quick break, time to practice some mindfulness and meditation, or a little bit of light exercise. That kind of thing will wind up paying dividends for companies. So I think it goes back to education. The problem with migraine, that it doesn't get the legitimacy it perhaps deserves as a medical condition, is that just about everybody has had a headache, and we sometimes confuse a headache with the disease state migraine, which is akin to having a tummy ache and confusing it with Crohn's disease. I mean, they're vastly different, but I think headache and migraine can sometimes be confused. So education, I think, would be the first step.
And I would just add to that one of the other considerations, particularly if if someone is just beginning to be treated for chronic migraine, it may be important if your employer is large enough to get FMLA status, so that if you have to miss work because of a migraine until you're on an effective treatment program, that you're not penalized. So the Family Medical Leave Act, if that is something that is part of what your employer is large enough to offer, that can really be important. And then sometimes, as Dr. McAllister pointed out, sometimes flexible work hours, sometimes sitting down. I would say that it is a challenging situation, because many times employers penalize people and they don't really understand the significance of migraine. So being very open with your doctor or the nurse practitioner, letting them know, are there things at your job that they might be able to do? If someone's sitting next to you that wears too much perfume, if there's too much noise, all those kinds of things, there may be those modifications. But sometimes it is important to have FMLA and to have a very structured approach to any absences that are there. And sort of going back to something Dr. DeLeonardo said, that's a place where we don't always capture the presenteeism. So I think there may be structural things, and again, trying to emphasize the importance of being there, and perhaps if you can work from home for some things, or those modifications, but also of having the capacity to take your medications and telling your doctor you may need something that really acts faster if you're treating an acute attack.
I think we have time for one more question. This one is from Tiago, wondering, given migraine is more common in women than men, if there's much research done in relation to migraine and men, and this is for any of the speakers.
Jan, you want to take a shot at that, or?
Well, certainly men are included in all the clinical trials, but as we've talked about, the numbers are higher in women because of the impact that estrogen has on a brain that has the predisposition to migraine. So I would say we have a lot of information, for example, in the current clinical research climate for the CGRP antagonist among patients who are enrolled in those clinical trials, but we really don't have the kind of differences outlined in terms of hormonal differences. We don't really have clear approaches to studying them that go across all clinical trial designs. And again, it's not really included in the secondary endpoints. So I think there are a lot of areas where we probably need to make some differences. For example, this is not about migraine, but just in terms of headache, cluster headache is more common in men than in women. And we know that those numbers are changing. It used to be a 5-to-1 ratio of men to women. Now it's about 3-to-1. And we don't really know why that is. So there really are a lot of areas where we need to see if there are sex differences in the disease state that can be explored in clinical trials, and certainly at a basic science level, because that may be key to why. It's interesting, Dr. DeLeonardo's, it was her maternal grandfather, then her mother, then she. So it clearly impacts in families, men and women. And so in a family like that, we need to understand their genetics better, and then we can begin to look at the separations that may be related to sex hormones.
Well, thank you, Dr. Brandis, and thank you to all the speakers for today's webinar. A quick wrap-up. For those whose questions we were not able to get to, please submit them to info@researchamerica.org, info@researchamerica.org, and we'll forward your questions to the speakers. And please include your contact information. Again, a special thank you to our panelists for sharing their time today with us and for responding to questions. After the webinar, participants will receive a short survey about today's program. We appreciate your feedback. And thank you again for joining us, and have a great rest of the day. Thank you.